retinoblastoma, present concepts, and looking forward, I have no financial relationship, but I have a clear passion about retinoblastoma and genetics. I'm the unpaid medical director of Impact Genetics, which does genetic testing. So the RB1 pointer, the RB1 gene can be tested in families. All bilaterally affected patients have a mutation in their RB1 gene, and we can find that in 97% of the cases, leaving 3% that we actually think will be mosaic at a level that we can't see it by all of the current technologies, but that's getting better and better there too. For unilateral patients, the unilateral, if we only have blood, the success to find a mutation is now about 16%, and that's very close to the old ancient breeding experiment when unilaterals had children with retinoblastoma, about 15% of them, so it's pretty accurate. If we have tumor from the unilateral patient, then we have essentially the same sensitivity to find the 2 mutant RB1 genes in the tumors. There is a new kind of retinoblastoma that has normal retinoblastoma genes and instead has high-level amplification of MYC-N. That's about 2% of unilateral patients. And I'll just divert to that for just a minute because it's very, very important. These children are very young. This is the age at diagnosis of the patients that have RB1 mutations in their tumors, all unilateral, no bilateral. And you can see these ones with the red triangles and one green. I won't bother explaining that now, but you can ask me later. The median age of unilaterals is about 24 months with RB1 knocked out. But the median age of those that have around 100 copies of the MYC-N oncogene in the tumors and normal RB is 4.5 months. So you can imagine that the initiation of that tumor is way before birth. It's a much different tumor. So when a child presents with advanced tumor at birth or shortly after, looking like this, an eye full of blood and tumor, that's a very dangerous eye because if it's a MYC-N tumor, as this one is in a 4-month-old, the tumor's already beyond the lamina cribrosa and into the optic nerve. So if you treated that eye with intraarterial chemotherapy, what would the result be? You would not see this on MRI. You can't see that level of sensitivity. MRI is not good enough for that. And I think the result would be pretty disastrous. So here's a little girl in Toronto. We think enucleation is a pretty good procedure. She was 4 months of age, group D unilateral. We did an enucleation of her right eye, no family history, and here she is 5 weeks after enucleation. She continues to look beautiful. Her pathology on the removed eye, we were able to confirm that there was no optic nerve invasion and no choroidal invasion. This eye looks a mess because we always open the eye in order to get tumor, in order to do the molecular work on the tumor, which was quite important for her. But this showed no high risk for extraocular disease, including carefully looking at all the collates. But the tumor that came out of the eye, we could find that the tumor had lost both copies. It wasn't a MYC-N tumor, which was good news and bad news. But the blood showed a mutation, that mutation in the tumor, from the tumor in the blood at 10%. So she's mosaic for one of the common mutations. And then, of course, she needed to have EUAs to watch for the other eye, and then she finally showed up with a little tiny tumor here, which was treated with laser, and that, in fact, has been her only treatment necessary. Mosaic is really interesting because we now can find it very well. If we look at all of the bilaterals that turn out to be mosaic carriers, it's about 6%. If we look at unilateral, when we have the tumor, in order to be able to look as we did in the child, so we're very accurate in looking for mosaicism if we have tumor, it's 38% of them. 50 of 131 that turned out to have a mutation are mosaic. So it's really, unilaterals have a high chance to be mosaic, and that probably is why they're unilateral, and maybe why they might have less risk for other tumors later in life too, but that's not measured and will take many, many years to know that for sure. The unilateral with no tumor, again, comes to the same very high figure of mosaicism, but it's interesting to me, and maybe think about this and let me know by email if you come up with some brilliant idea, that the overall mosaicism rate for unilaterals and bilaterals is the same. So it's not two diseases, hereditary and non-hereditary. It's one disease, and it's a matter of the density of mosaicism. To me, that's a pretty interesting idea.
Is it?
Yeah. It's not two diseases, it's one. Back to the RB1 mutation sensitivity and why it's important. Here, if you had 90% sensitivity, meaning in a bilateral, not 10% you would not find the answer, but you might be tempted to conclude they didn't have it. That would be giving you a residual risk of 1.5% that they actually carried the mutation. If you're up to 96 or 97%, then that risk gets below 1%. So what we recommend is less than 1% risk clinical surveillance is altered, and so no EUAs. You still would see them in the clinic. Continued non-invasive screening for the normal eye, but that means just a clinic visit with ultrasound maybe. And future offspring would require no EUAs because you could test them very accurately, and they don't only clinic visits. So it's pretty exciting at the American Academy, at the American Association of Ophthalmic Oncology Pathology, I think that's right. Alison Scallett from Oregon Casey Eye Institute brought the group together for a consensus conference on what do you do when you have different genetics results, what follow-up do you do, what screening protocol should be. So I'll just quickly run through it. If the patient has a known germline, you prove it anyway. The parent has bilateral retinoblastoma. The patient, if the parent has bilateral, the child's at 50% risk. And those need EUAs. Those are EUAs. These are awake clinic exams on an infant, and you don't need any EUA until they're 6 months old because you can see the whole retina without anesthetic. If the patient had unilateral retinoblastoma, that patient would be at 50%, 15%, or 16%, whatever. And they need some EUAs, but not quite as many because of the risk is a little bit lower. And if they're unilateral with no RB1 mutation demonstrated in blood, they hit this magic less than 1%, so they don't need any EUAs. Carrying on, parent has unilateral retinoblastoma, but no mutation found, so 7.5%, et cetera, going down. But when their parent is unilateral and the child has a negative blood test for 2 RB1 mutations from the parent's tumor, that proves their normal population. They are at 0 risk, and that's quite nice. They need nothing more. Don't spend any more money. Send them to private school and make them smart instead. The sibling of the child with bilateral, and this goes on and on and on. I'll go through this table. So this is the core outcome of that consensus group, and I hope that this is followed up with a real guideline for surveillance for these children in the U.S., which would be the first closest thing to guidelines from the U.S. that would be emerging, and that would be very exciting. So I'll just jump to what Ashwin introduced very nicely, the hereditary TNM, and this is showing it in the context of our cancer care database, which I'm not going to talk about more right now, but it is a complete database for a summary of all the work you do for retinoblastoma, all the features you need to know, but its value is that it's at the point of care, so you fill out the data as you're seeing the patient, and so it makes it a very rich data set sitting there waiting for other things. And we've added to it the heritable trait, and if these boxes were checked off and then you'd fill in the exact definition of the mutation, you push a button and it calculates the stage. We will have filled in all sorts of other things for this is now running the 2016 TNM algorithm to stage, and it's a T2A is the overall clinical stage, and the H1 because we know the mutation. And the question previously, if bilateral or trilateral disease or family history makes it close family history, because there certainly are remote second cousins that don't mean the patient in front of you has an RB1 mutation at all. So just to summarize quickly the opportunities and challenges for retinoblastoma genetics right now, it's very exciting. EUAs are unnecessary for children at less than 1% risk, and this group all agreed with that. However, the challenge is that there are many ophthalmologists around the world still doing EUAs because they don't quite trust it. Is that why they're doing the EUAs? Anyway, once it gets to be a consensus document as a guideline, that will perhaps save these children from unnecessary EUAs. Early delivery, if the prenatal test for familial RB1 mutation, that's the parent's mutation, and they test the child by amniocentesis, that takes the result to from a 50% risk to 100% risk if the child carries it. And then you deliver the child early. That improves ocular salvage and function with less therapy required. And I haven't given more details on that because it's being presented at ARVO in 2016. More challenges, though. Absence of genetic counselors. There's no profession of genetic counselors in China, as far as I'm aware. There is a great shortage in India. I think several years ago I met a group who were trying to promote genetic counseling as a profession. But for us to hand the family the mutation or expect us to, the very busy doctors, ophthalmologists, untrained in genetics, let alone how to counsel, because it's a very delicate job, puts all of the work, molecular work, at great risk. And an example of that is the variants of unknown significance. So with great, beautiful technologies, you can sequence the whole genome of the person. You can find all sorts of things will show up there, but they're not mutations. They're just changes in the gene, in the sequence. And I know of one example where, with no counseling, the family aborted a child who carried the variant of unknown significance because they didn't know what that meant. So we have a big crisis in genetic counseling. We need to really, as a group here, promote real professional genetic counseling. Lab test sensitivity is critical. We've already talked about that for care. So that's all I wanted to say. Thank you.